we've got your mate, JB. JB, we'll get him on the WhatsApp.
Go on.
That's right. Okay, may as well start. So I've just got a pile of cases here today. We'll go through them. We'll go off on a lot of tangents, that's for sure. I don't know if we'll get through the entire one. I know some of the RBH people have seen some of these cases before. Yeah, as I say, it's not all about making the diagnosis. It's about going off on tangents, thinking, what might I need to know to pass this in an exam? This is actually a case just from this week. A few more people returning to the Royal. Colonic mass in a young woman. Might just get people at the Royal to comment if they like. Anyone have any comments about this?
Look, colorectal and possibly endometrial, one first impression, but I don't have to. They've got the 8-foot snouting columnar, but they don't look dysplastic.
Yeah.
So yeah, I'm not sure about the surrounding stroma, it's quite inflamed, but as just the very first impression, I keep endometriosis in my mind.
Yeah, there's a few cystic lesions over here, again lined by very bland epithelium. So, how would you go about confirming that?
I could do a CD10 type of look across the surrounding endometrial stroma, after the glance.
Yeah, I did CD10, it didn't work very well.
No.
This is estrogen receptor. And see how it's staining the epithelium and the stroma there, and also did Pax8 immunohistochemistry. You can see that that's nicely reacting with the epithelium.
Yep.
Is endometriosis rare in the gastrointestinal tract?
There's a lot in side sets, but in real life I'm not sure of the frequency.
Yeah, apparently it's like the commonest site outside of the urogenital tract. So yeah, it does occur with some frequency. Now this case is so easy because you've got those isolated glands surrounded by the stroma. But I've seen cases which were a lot subtler than this, where you just have, where is it? Yeah, you might have almost normal mucosa, and then a couple of, how it works, a couple of glands that just look different sitting in the middle of otherwise normal colorectal glands, and they're really tough unless you're thinking about it. Very easily misdiagnosed as adenoma. In a subtle example, I say this is a piece of cake, this one. So as I say, we go on some tangents today. So what are the pathogenic, how is endometriosis thought to occur? What are the pathogenic theories? This could be a written question. Going back to Robbins. Pardon?
Ectopic endometrium.
Yeah, but how does it get there? That's the definition.
Like dissemination.
Retrograde restoration is one.
That's one.
One is like methylation.
Sorry?
Like arising from like stem cells or something.
Yeah.
One. Therefore.
So according to Robbins, which I just looked at half an hour ago, the two main theories is it comes from endometrial tissue from the endometrium, which can get there either by retrograde menstruation or spread through the blood. And then the other idea is that it comes from other cells, which then differentiate towards endometrium. So that might be peritoneal cells, or it might be stem cells in the blood. You know, why it happens, I don't know, but that's the theories according to Robbins. And then you should know the types of ovarian cancer classically associated with endometriosis. What are they?
Clear cell.
Clear cell and
Endometrial.
yeah. So these are the type of questions that, you should go through your head every time you see endometriosis. So be on the lookout if you have like a colonic biopsy, they say it's a mass, it looks weird, you think, oh, it might be an adenoma, but it just doesn't look quite right. Just if it's a female, think about endometriosis. They can give you endometriosis in any organ of the body, it's fair game in exams. Okay, ovarian liver. This was resected for a mass. I think it was thought to be a cholangiocarcinoma. Anyone want to chip in with this easy diagnosis?
Tablets major.
Yep, that's right. Cavernous hemangioma. So are these rare lesions or common lesions?
It's common.
Yeah, they're very common. So they're the commonest liver tumour, pretty much. But my understanding is that they're often pretty easily diagnosed radiologically, so they're not often resected. And if they have a benign course and you know what it is, what's the point in resecting it? I guess they're resected if there's complications from it, or I guess more frequently if it's misdiagnosed radiologically, like this one was thought to be a cholangiocarcinoma. I guess some of them don't always follow the radiological diagnosis rules. So this one's pretty straightforward. Blood vessels lined by very bland endothelium without mitotic activity. So Shiva, can you name any other vascular tumours you see in the liver with some frequency?
You could get itchy.
Yeah.
Angiosarcoma.
Yeah.
And AEM.
Yes, I can't recall ever seeing that. But yeah, you're spot on. So yes, hemangioma is very common. Epithelioid hemangioendothelioma is the other one, and angiosarcoma. So which other organs of the body can you see epithelioid hemangioendothelioma with some frequency?
Not sure.
Anyone? Lung?
Soft tissue.
Yeah.
Lots of places.
So I think there was a lung one in the QAP this year, or recently anyway. And what immunohistochemistry, we don't have it, but what immunohistochemistry can you do for EHE?
It's camped.
Campton one. So that's useful if you're not sure whether you're dealing with an epithelioid hemangioendothelioma or an angiosarcoma. Otherwise hemangioma, yeah, it's pretty easy in a straightforward case. And can you name a few endothelial markers?
CD31, CD34. AEG.
Yeah, that's right. I think I showed something like this recently to the RBH people. I think we're in the esophagus here. It's squamous mucosa somewhere. Looks like we have an ulcer and all of this debris. Nice easy one. Does anyone know what this stuff is?
L fragments.
Yep, specifically.
Sevella there or Sevella?
Yep, that's right. So what are the other types of resins you can see?
KXLate.
Yep, KXLate, that's right.
Iron tablets, iron pill, the ferrous look.
Yep, so there's three main types of resin. This is the Sevellima, and you pick it pretty much by that colour. It often looks a bit reddy yellow. It's got a very prominent fish scale look to it. Like that. KXLate is, actually this absorbs bicarbonate, I think, in the gut. So the people who take this are usually like chronic renal failure type people. So they're on dialysis. So that's a clue. But the other one, KXLate, there are also people who have chronic renal failure. That's a potassium binder. So my understanding is it just binds these ions in the gut so that the gut does not absorb them and they end up in the blood, and then the kidneys have to deal with getting rid of that potassium and bicarbonate. So the KXLate's very, very dark blue, so it has a different colour to it. And then the other one is cholestyramine, which you don't see too often. It's much more red, I think. So it used to be used for hypercholesterolemia, but now there's better drugs for that, like statins. But now it's only used rarely. So it's just thought to be an innocent bystander here. It's probably just caught up in a benign ulcer of another cause. I believe that K-exolate can cause some problems, but Sevelamer doesn't.
I thought Sevelamer was phosphate binder.
Phosphate, you might be right. I might be getting my ions confused.
I'll look it up because I'm
Yeah, look it up, let us know.
yeah, it says phosphate binder. According to Google.
Phosphate, okay, sorry. Getting confused with something else then. And then there's other debris here. This is the cross-povidone that all the registrars here know that I pointed out all the time. It's little things that look like coralline material, sort of a mixture of purple and pink. So it's very, very common in drugs, in tablets. Let's polarize this, see if we can find some cellulose as well. That's the other main type of tablet debris. Oh yeah, there is something birefringent in there. So the cross-povidone, I'm sure you're all sick of me saying that, I think it was first described by pulmonary pathologists who discovered it in people who have aspirated tablets. So if you see it in the lungs, think of aspiration pneumonia, or if it's in the blood vessels in lungs, IV drug use. So we're in the stomach now. Looks sort of a bit reactive, doesn't it? Like there's mucin depletion and a bit of foveolar hyperplasia. And then this quite characteristic lesion. I'm sure some of you know what it is. Anyone?
It's like fibrin thrombi or like ring.
Yeah, it's sort of fibrinoid, but it's not like what you would expect if it was a fibrin thrombus, because a fibrin thrombus would be like a solid mass in a like a tube. This sort of looks like it's the tube itself that's bright pink. So it's not quite right for a fibrin thrombus.
It reminds me of like the doxycycline.
Well, that's because that's what it is. So this is doxycycline-induced injury to the stomach, very characteristic. If you've seen it, if you've never seen it, it's very confusing. So that's pretty much it. It's just reactive gastropathy with that sort of fibrinoid material in superficial blood vessels. Now you can get damage to the esophagus in people taking doxycycline, but it doesn't cause this pattern. It just causes a non-specific ulcer or erosion. So for some reason, it just seems to be specific for the stomach. So you might almost wonder if it's an artifact when you first see it, but that's it. So I think a good idea for you guys might be to come up with like a list of drugs that cause characteristic features in the GIT. I mean, we've seen a couple already. We've seen the resins, we've seen doxycycline. Obviously, things like iron tablets are pretty characteristic. You find that crystalline debris that's Peebles positive.
Ultrasound, the brain emerges.
Yeah. And then some cause non-specific injury, like non-steroidals and things like that, whether you'd never pick without the history. Which organ are we in?
Pancreas.
Pancreas, yep. So it looks a bit like parotid, but of course you have the islets of Langerhans. tumour sitting in it. So this is pretty representative. Does anyone have any ideas what this might be?
Nests of twin cells. Either like a serous adenoma or a metastatic plastic.
This is metastatic renal cell carcinoma. And I'll put this in for a couple of reasons. One is you need to learn to recognise tumours out of where you expect to see them. And renal cell carcinoma does pop up in weird places. And I've seen it, skin metastasis. You get weird deposits. I think you can go to the thyroid as well. So you have to learn to recognise tumours where they don't belong. In one of my exams, they gave us a bit of bone, and they said bone lesion or something. It was extremely vague. I stared at it for about 10 minutes before I realised it had whorls in it. It was a meningioma, and it was skull. But they didn't give that away. You had to sort of infer it. And again, I only recognised it because I recognised the whorls. So this had a history of metastatic renal cell carcinoma. I don't know why they chopped it out. It showed appropriate immunohistochemistry. Oh, that's right. And the other thing I was going to say is, I know it's a lot of work, but I think it would be a good idea for you guys to try to learn like the WHO list of tumours for certain organs, particularly the ones that have a lot of uncommon types like kidney, clear cell and papillary and translocation tumours, all of those. Because then when you see something that's a bit weird, you can run down that list and go, no, it's not that, it's not that. Well, it might be that. And it might just remind you of something that you've never thought of. Salivary glands would be another one, there's so many of those uncommon salivary gland tumours. And to have that list in your head, I think, would be very advantageous going into the exam. It's a lot of work, and I never did it myself, but if you can spare the brain power, just learn the WHO classification of things like kidney, thyroid, salivary glands, etc. Yep, so that's a nice easy one. Okay, this is a resection. It's gastroesophageal junction. We have gastric type mucosa there, a bit of squamous there. Nice submucosal glands. So that's one of the ways, if you have an EMR specimen, endoscopic mucosal resection, you can tell you're actually in the submucosa. I'm sure you're aware that in things like Barrett's esophagus, you can get marked reduplication of the muscularis mucosae. So if you have a cancer going down, you can't just rely on the fact that it's below muscle to say it's in the submucosa. You need better evidence than that. And the best evidence is submucosal glands, because you don't get them up in the mucosa, and thick walled blood vessels, because you don't see those up in the mucosa. So we're not talking about EMRs now, but just while I thought of it, I thought I'd point that out to you. The reason this is in because of this lesion. Okay, I guess the plane, it looks like it's in submucosa. Okay, this is probably pretty easy for people preparing for the exam. Anyone? Yep, nice. So immunohistochemically, it would be S100 positive, you'd have PAS positive granules. So these can pop up in lots of different places. I've seen them in the colorectum, get them in soft tissue, skin, things like that. I remember when I was a registrar, we learned you get them in the tongue and the esophagus, and of course the trap of the esophagus is it can lead to pseudoepitheliomatous hyperplasia. And if you're not specifically looking at the lamina propria, you can miss those tumour cells and call it an SCC. So that's definitely a trap for exams. And this probably is inducing a bit of hyperplasia, isn't it? Look how thick that epithelium is. And of course, you know, just keep looking around, look for second pathologies. That's pretty inflamed to my eyes. And this had Helicobacter when I did immunohistochemistry. So keep an eye out for that second pathology. So nice plasma cells in here. Just going to find, can't see it. Just try to point out Russell bodies. Probably Russell body there, and pink material expanding the plasma cell. How's that for a clock-face chromatin? Oops, it's perfect. Oops, it's not on the screen. Let's see. Oops, can't find it now. Anyway, it was nice. And then what do you call that little pale area next to the Hoff? Yeah. Had to look up what Hoff meant. It's an old German word, but I think it means enclosure. So I guess you've got a little bit of pale cytoplasm surrounded by the darker cytoplasm. Yep, so granular cell tumour, that's definitely a part 1 favourite. Repetition's always good. This is a bit of liver. The cavernous hemangioma. This one's a lot more congested. As I say, when you're studying by yourself and you come across these, just run through the list of vascular lesions of the liver. How might you distinguish them all? You know, think about epithelioid hemangioendothelioma. That can certainly pop up in exams. Yeah, that's about it. But this one's very straightforward. Oops, go and find it. Yeah, this is very characteristic. If you've seen a few, this was a mass in the mesentery. I think it was done at the time of something unrelated anyway. It's like a bowel cancer. Does anyone know what this is? Yep, calcifying fibrous tumour. Hypocellular fibrous tissue with this characteristic calcification. One thing that you often see are the plasma cells at the periphery. This has a nice example of plasma cells. I don't know much more than what I've told you, but they're pretty characteristic. I think they can pop up in other organs as well, but I usually see them in the mesentery or peritoneum. While we're here, can someone tell me about calcium stains? What's our go-to calcium stain? Oncosa. And does that stain every type of calcium salt?
Just hydroxyapatite.
Sorry?
Just hydroxyapatite, not the oxalate.
Not the oxalate. So what might you use to stain calcium oxalate?
Never had to before.
No, you don't usually have to. Alizarin red. Seem like Bancroft and Stevens in those books. Remember, you've always got to think of calcium oxalate if you have like a breast core and they say there's calcification, but you can't see this purpley cracked material on the slide, so make sure you polarize it. So that's how you can find calcium oxalate. Sometimes a good tip is to look for tears in the section, because when they cut the section in the lab, if there's calcification, it can just tear right from one side to the other. I can't see any tearing in this slide. And what material do we decalcify tissues with?
EDTA.
Yeah, that's right. I knew the answer I'd ask what that stood for, but EDTA is good enough.
You didn't ask.
Ethylene something. This is a nice, easy part-time question. I think this is small bowel. Sorry?
Urine.
Now this would be a complete gimme. And maybe they could give you something like this, but in an unexpected place like a lymph node, a liver biopsy, you might get this, might be near some weird metastasis. But it's definitely something you need to recognise in isolation. Very monotonous cytology. Of course, you need to know how to grade them. Won't go into that, but you definitely need to know how to grade them. And always keep, looking around for second pathologies. So what's going on out here?
The lifting agent.
Yeah, good point, but no. I guess they don't normally get into the small bowel to biopsy things. Sorry, you said it looks like?
Amyloid.
Amyloid, yeah. It looks a lot like amyloid to me. It's got that hypocellular eosinophilic look with all of that cracking within it. So what's the gold standard test for the diagnosis of amyloid? Congo red. The gold standard test for classification of amyloid? Yeah. So you can attempt immunohistochemistry, but it's rubbish because you often get just very pale brown reactivity for everything. And it's hard to tell what's stronger, what's weaker. I mean, I always tried, but always end up saying immunohistochemistry was attempted, but it's non-contributory. So the best way of classification is mass spec, which I think they're getting at the PA. Duncan Lambie told me it's not the type of thing that we'll be able to request. We'll have to go through like an amyloid clinic. There's a haematologist there who's really into amyloid, and I guess they'd have to refer to him and he would have to give the approval. So what's the ultrastructural appearance of amyloid?
Beta-pleated sheets.
No, it is not. Can you see beta-pleated sheets by here?
8 to 10 nanometer fibrils that are non-branching.
That's correct. So they look a bit like spaghetti. So the beta-pleated sheets are at a much, much higher magnification level than that. So you can't see them. I think they infer that with crystallography, which is something we don't do. So yeah, do not say beta-pleated sheets in an exam. So this was an additional slide taken from this person, and that's the most amyloid you will ever see in one slide in your life. It's very, very impressive. It's the Congo red. So they describe a salmon pink colour. Try to polarise it, see if it works.
Might have to move it colour.
It doesn't. I mean, it definitely does on my microscope. I think probably here is with this microscope and the optics. Oh, hang on. Yeah, sorry. Yeah, I remember what I mean. But it was definitely, there's a bit green there on the screen. I mean, other stains you can do is crystal violet. Dr. Whedon used to like doing that on the skin. He liked that much more than than a Congo red. I can't remember why. Something called thioflavin T, which I think we can do here, but I think you need the IF microscope to look at that. But yeah, that's a good one. Oh, so what are the main types of amyloid? Sorry, AL? What else? Yep.
And then it's ATCR.
Yep. that will cover most of them. Then there'll be much rarer ones. That's right. Okay, this was wedge resection of stomach. So we have a mass, seems to be centered on the submucosa. So the muscularis propria is out there. Inside it looks like it's ulcerated, it's just getting into the mucosa. So immediately it's a bit fishy for GIST, isn't it? GIST usually arises or is centered in the muscularis propria. So it's slightly wrong for a GIST. So let's have a look at high magnification. So what does anyone think?
Looks really nice.
I'll have a DD.
Yeah, it looks a bit like smooth muscle. What have you got here? Mitosis. Mitosis. Yeah, leiomyosarcoma. You of course have to confirm it with immunohistochemistry, and this did tick all the boxes for smooth muscle differentiation. Leiomyosarcomas of the GIT are very rare, but I saw about 3 in about 6 months, so they're not that rare, I imagine. There are no hard and fast mitotic rate cutoffs for the GIT because they are rare and they haven't really, the analysis hasn't been done. But in Odd's textbook, they said anything with a bit of atypia and at least one mitosis should be treated, I guess, with great suspicion. And look at this, it's just mitoses galore. There's also atypia. I mean, it's not pleomorphic, but it's definitely more than what you'd want to see in a leiomyoma. And there is necrosis. Let's see if I can find that. There's some necrosis.
In practice, they're usually just very obvious leiomyosarcomas. Do you ever get ones where you're kind of not sure, like it's on the lower end, looks like very naughty?
Well, yeah, I haven't seen many, but I would think it's pretty obvious otherwise.
Yeah.
Yeah. And the other thing that made me think here, this is malignant. Look, it's invading the mucosa. It's not pushing; it's really invading, like its fingers going up between the glands. I think we might have diagnosed this on a biopsy. I just can't remember. But yeah, that's pretty uncommon. You won't get that in an exam, but I guess be prepared for uterine smooth muscle tumours. Try to remind yourself of the criteria. I can't remember if they still call things stump.
Only in the uterus.
Only in the uterus, yeah. And I vaguely recall that there's different criteria depending whether it's myxoid or epithelioid. Yeah, just try to learn all that for your exam.
Can you get some plastic ones in the GIT?
I doubt it.
They wouldn't be necessarily if they were tumor associated, like if H associated.
Okay. Yep, we're in the liver. It's a bit odd, isn't it? It's not what you were expecting. Sort of looks vaguely glandular in areas, but I think that's pseudoglandular and not true glands. I can tell you this is not an adenocarcinoma. Sorry?
Is it not like it's a bit discohesive, only about melanoma?
Yep, melanoma is definitely a possibility, but it isn't. Lymphoid is not lymphoid. Let's see if I can give you a clue up here. Yeah, that's definitely a good thought. Definitely a good thought, but it isn't angiosarcoma. So it has a sort of pseudo-angiomatous look, doesn't it? That's your clue.
Thyroid.
It's medullary thyroid cancer. So how would you confirm that?
Calcitonin.
That's the calcitonin. So it's staining the tumour cells and the amyloid as well. And it was resected, so here's the resection. It's a bit wild looking. It's not more wild than that endocrine tumour I showed you in the small bowel. But the tip really is the clue is the amyloid. So can you think of any other tumours that produce amyloid other than medullary thyroid cancer?
Insulinoma.
Yep, that's right.
Plasma cell neoplasms.
Yep, that's right. Oh, that's right. We were talking about with you the other day, weren't we, Ali?
So,
And then the other one that's probably much more common is BCCs. I think you can frequently see amyloid in BCCs. That's probably keratin type amyloid. So if someone's going to show you medullary thyroid cancer, they're going to ask you what MEN syndrome is associated with medullary thyroid cancers.
2A, 2B.
Yep, that's right. And what gene is mutated?
RET.
RET. How many MEN syndromes are there now?
Still 3.
No, it's not 3.
4.
No, it's not 4. It's 5. So look that up if you don't know. So you would suspect an MEN syndrome if someone had multifocal medullary thyroid cancer, if you took out their thyroid or they had C-cell hyperplasia and that sort of thing. The other features of MEN2 are paragangliomas. Oh yeah, and so they're TTF1 positive as well. Someone did a TTF1 on that. But they would be thyroglobulin negative. So it's sort of thyroid derived, but they're not thyroglobulin producing cells. Can't remember what these things are, it's like a lucky dip. Oh yeah, I love this one, I had it yesterday. So it's stomach. Chronic inflammation. Oops, can't go higher than that.
Was it Helen?
Yep, Helicobacter halmanii.
No, Helen.
Unfortunately, I can't go to higher magnification than that. I don't want to put oil on this, but so they're much bigger than your typical H. pylori. Probably the people here can maybe just imagine that they're a bit spiral. So you notice when you go from a really, really good new microscope to an old one. You see how long and straight they are. They're not the short seagull appearance of H. pylori. So this is, they're pathogenic. It's just a different species. I think I can find any better examples than that. But on a good microscope, you can definitely make out the spiral nature of those. So if you did Helicobacter IHC, would that be positive? Oh wow, look at that, it's a big party.
Is it specific for H. pylori now?
No, it's not.
Oh,
It
okay.
would be positive. So again, in the old days, we used to have part 1 vivas and part 2 vivas, and the part 1 vivas, as someone said, oh, it's often just a see whether you've seen a lot of histo. And they'd ask these sorts of questions. And if you got them wrong, the examiner would know you haven't looked at a lot of histo. So there you go, H. Hunmanii.
Are they also associated with the mold risks?
I don't know, I assume so. Okay, this I won't trouble you with too much. It's a bit confusing, but this is a case of Crohn's disease. So we've got one loop of, I think, a small bowel here, another loop of bowel there with looks like a fistula. So there was a fistula between these, but what I was hoping to show you was in here. Does anyone know what these things are?
Pulse granuloma.
Yeah, exactly. Good. Pulse granuloma. Where were they first described? What part of the body?
Gums.
Yep, that's right. Periodontal disease. So it's still a bit controversial as to whether what we're looking at there are plant cells or whether it's human material that's just looking a bit like plant cells. Imagine they would have been able to sort that out by now, but it's a bit controversial. So people also call them hyaline rings. So you can see that they're these rounded structures. They're often a little bit calcified and associated with a giant cell reaction. I know that a lot of registrars don't recognise pulse granulomas. So yeah, first described in people with poor dentition in the gums, and then with time people started recognising them in association with the gastrointestinal tract, particularly in association with diverticular disease and fistulas and things like that. So there's another one there. And the rest of the stuff here is just like granulation tissue. So once you recognise it, it's pretty obvious. Oh, that's a little cute thing I saw the other day. It's just a colonic polyp. Nice. Hemangioma. You don't see many of these. When I looked it up in the book, they say they're pretty common, but they must just leave them alone because you see about 3 in my years here. Very uncommon. And I don't think it's an angiodysplasia. Angiodysplasia would be much larger, fewer thin-walled blood vessels. This is very discrete. Okay. I think this is a stomach with intestinal metaplasia, so I might take a bit of hunting around. Oh no, that's pretty much it. So we've got giant cells, quite superficial, and something going on. It's really hard to put your head around what's going on. There's a pale grey material, maybe it's intracellular. Can't remember whether this is birefringent or not. Maybe not. Whoops. No, at least not on the screen. And once you get your eye in, there's quite a bit of it. It's there again. Very subtle, but in there as well. Does anyone know what this is?
Barium.
Barium is a good thought because it looks similar, but it isn't. But it is a medication.
The only time I've seen that pale grey was like in the aluminium in the vaccination. So it reminds me
It's not that.
I can get into that.
This is, anyone last, it's another renal patient. Sorry? No, it's not iron. Iron is much different. It's really crystalline looking.
Cholesterol.
It's not cholestyramine. This is lanthanum. It might be the bicarbonate binder that I was getting confused about. It's pretty uncommon. I've only seen a few cases of it. And unless you're aware of it, you're going to miss it. But I guess just think about it. I can promise you this won't be on the exam, but this is just for your interest. You know, if you see macrophages with this sort of pale grey, weird-looking stuff, and you look up and they're a renal patient, consider lanthanum. And then this is another patient with lanthanum. Just see if I can find it. So it's out there, if you look. Maybe I picked up not the best slide. No, sorry, I can't find it. Wasted your time. But lanthanum, yep. Probably never seen that before. No idea why they took biopsies on this person, but I'm glad they did. What's that there? I think someone grumbled colchicine. It isn't, but it's the other drug that can cause this. So see if I can find some other examples for you. Do you know what it could be? Sorry, I put a dot on it. There's another almost horseshoe-shaped mitosis. Oh, there's some more here. See, so they've got these really weird mitoses. Some of them which are clearly ring-shaped. No idea? It's taxanes, which are a type of chemotherapy. The main one they use here is paclitaxel, and this lady has ovarian cancer. She was started on paclitaxel about 1 day before this biopsy was done. So this is paclitaxel effect. But colchicine would look exactly the same. Just see if I can find some more for you. So if you see it in someone with colchicine, that's said to be an emergency because it indicates toxicity, and you need to ring the clinician and tell them, because if you don't, they might die. Whereas here, this is just an expected response to the drug. See, there's another one there. Somehow it interferes with the spindle, you know, the spindle where the chromosomes line up, and they all get a bit confused. There's no one there. And there's also apoptosis. See apoptosis there, and there, and here. Some people from the Royal have seen this one, but this is someone with like an 11 centimetre mass in their pancreas. It's not your typical ductal carcinoma, it's ductal carcinoma. It's glands separated by fibrous stroma. This looks completely different. This is a very cellular, solid type tumour. Sorry, I'm getting old and deaf.
So is it pancreatic acina?
Yes. So it's acinar cell carcinoma. The major differential diagnosis is going to be a neuroendocrine tumour. So I definitely did neuroendocrine markers on this, which were completely negative. And what immunohistochemistry would you do?
Tryptase.
Tryptase, did you say?
Yeah.
No.
Trypsin, sorry, brain. Yeah.
People get confused. So tryptase is something you get in mast cells.
Yeah.
Trypsin is what you need to do. And don't say alpha-1 antitrypsin, because that's wrong as well. So you need to think of it when you see a solid tumour in the pancreas that looks like it might be neuroendocrine, but you have prominent nucleoli. You don't normally see nucleoli in neuroendocrine tumours, okay? So that's a clue that it's not a neuroendocrine tumour. And also there were quite a few mitotic figures. So of course you can get grade 2, grade 3 neuroendocrine tumours, but if you're ever entertaining that in the pancreas, make sure you rule out an acinar cell carcinoma. After you do a PAS, you can sometimes see some granularity to the cytoplasm. Oops. In some of these cells, it definitely looks granular. You know, up here, for example, cytoplasm looks granular. I guess you've got to be careful that you don't look at that and go, oh, that's mucin. I'm not sure why that's PAS positive, but it's not a ductal carcinoma. And let's see, here's the trypsin. That's positive. There's one other marker the books talk about, and that's BCL10. We don't have that. They have it, Anthony Gill has it in Sydney. So I guess if ever you're really strongly suspecting it, but your trypsin is negative, you might be able to do BCL10 immunohistochemistry. I can't remember how these behave, but I think they're pretty bad. But I'd always think about neuroendocrine and acinar cell when you have a solid tumour in the pancreas, I guess, as well as the solid pseudopapillary neoplasm. It's the wrong clinical history, and I think I did things like CD10, etc. It's not all negative. Yeah, I can see I did beta-catenin, that was negative. Oh, this is the easiest of the day. Maybe I should pick on our most junior person. Is that you, Casey?
Yes.
So this is duodenum. And we've got this is a duodenum. What do you think that is? No, something we looked at about 20 times today. What are all the pink cells? What about up here? Does that look like duodenum?
No. They're goblet cells.
What part of the body does that look like?
Stomach.
Yeah. So how do you explain that finding in the duodenum? Oh, that's all right. It's gastric heterotopia. And it's very common, and I see it all the time. But I put this in not because it's a tough case, but just to remind you of different types of heterotopia. I think that would be a good list for you to make up and memorise. You can get gastric heterotopia in the esophagus, you can get sebaceous heterotopias in the esophagus, you can get pancreatic heterotopias around different parts of the abdomen, and the stomach, and in Meckel's diverticulum and things like that. Can't think of many others off the top of my head. I think you can get like glial heterotopias up the nose. That would be a good list to learn. And also when I put this in, I wanted to remind you that there's a nice list in row's eye of benign inclusions in lymph nodes. So that's a good list to have. So you can see salivary gland tissue and breast tissue, mesothelial cells, Müllerian inclusions, nevus cells in lymph nodes. So that's a good list to have so that you don't immediately jump to some sort of tumour. Some of them must be really hard to distinguish from tumours, like thyroid tissue. But yeah, good list to learn if you can. Oops. So these are tissue cores from a gastric mass. This is pretty representative. Anyone have any comments? Yeah. Thelioid gist. It's paranuclear vacuoles there. Not to be confused with mucin vacuoles in adenocarcinoma. So of course I did a full panel of immunohistochemistry. It was keratin negative. That's KIT. So there's no doubt about it. Some lecturer I went to, Jason Hornick, said, don't call it C-KIT anymore, it's just KIT. I don't know why he said, I couldn't understand what he was talking about, but KIT. So this was someone who was about, 23, was in his stomach, it's epithelioid. So that's the end of the story. So which SDH? How would you interpret that?
Loss.
What's normal?
10. I think I'm sure. Right,
Yeah, so you always have a control, you've got normal tissue. In which part of the cell do you find SDH? Yeah. So which metabolic pathway is it? Krebs cycle, that's right. So you're expecting a finely granular pattern. So SDHB is your initial screen. So it doesn't tell you it's an SDHB problem. I think the only other one you can do is SDHA, which is what this is. So it's got finely granular cytoplasmic reactivity. So it's not an SDHA problem. It's going to be SDHB, C, or D.
Okay, so the IHC for B covers B, C, D.
Does it cover them all?
Yeah, B covers them all. But here we have the added access to A, which is
Right.
retained. So what does this mean for the patient? What's the significance of an SDH deficient?
Can you associate with Carney's trial?
Worst.
Yeah, it can be part of Carney's triad. Or what else?
Carney's triad.
Yeah, which is part of what?
It's a dyad. You get like paradigm, SDH deficient paraganglioma and SDH deficient gist. There's autosomal dominant.
Yep. So I had to write it down in my hand because otherwise I forget. WHO calls them SDH deficient tumour syndromes.
Okay.
So if you have a germline mutation of one of those genes, then you have SDH deficient tumour syndrome. Carney-Strakakis, I think, is part of that, but I think that's probably not a preferred term now. So the other main feature, as you said, is paraganglioma, which is why we always do SDH IHC in paragangliomas.
And when do you do PDGFRA molecular? Is that when the kid's
Familial
negative?
gist.
Oh, familiar. Okay.
So, yeah, we don't do it.
You don't,
I
it's
think
once it's good.
sometimes it's like there's no c-KIT mutation and it's
Yeah.
metastatic because there's a treatment for it. but it would be clinician.
So so what's in the Carney triad?
Ordinary co-driver as well as the Paragantia.
Yep. So is that hereditary?
No, it's due to hypermethylation.
So we can't tell whether she has a hereditary syndrome or Carney triad. There's some way of doing it, but it's not widely acceptable. Widely available. So yeah, in an exam you might have a resection of an epithelial cyst in the stomach, and if you notice it's a young person, you'd better say you do SDH testing. I asked Suraj once, do we do SDH on all of our paragangliomas/VOs? He said yes. But I think in those syndromes, you mainly get them in the adrenal gland. You don't get extra adrenal paragangliomas. Okay, this is some lady who had half her colon taken out. She had 3 big lesions. That's one of them. That's another one of them. Oh, that's another one of them. And then we found all of these as well. Any idea what's going on here?
Polyposis syndrome,
Yep.
missing FAP.
I don't know if you can tell by looking at it.
I was just going epidemiologically.
Yeah, well, I think she was too old to have classic FAP. Like she was in her 20s or something, and she didn't have the carpet. I mean, there were quite a lot, but it wasn't textbook carpet-like. And notice how some of these are just minute. And I found like 1 or 2 like single gland adenomas. So she certainly has some sort of adenomatous polyposis syndrome. So what would your differential be then? You mentioned FAP, that's definitely a possibility. So I think she was, I can't remember her age, but she was definitely too old for the usual type.
So then, I guess was Lynch syndrome you did there, but these aren't of the SSL type. So
Do people with Lynch syndrome get SSLs?
oh no, sorry, I'm muddled there.
It's very easy to get muddled. They do not. So cancers arising in Lynch syndrome usually arise from conventional adenomas.
Calvin's gets a lot.
Yeah, not purely adenomatous.
Attenuated FAP.
Attenuated FAP is definitely a possibility. Anything else?
And mute Y associated.
Mute by H is definitely a possibility. And then there's another like rare one that you probably haven't heard of. It's one of those polymerase proofreading ones, Pol-E, Pol-D, that you'll come across when you read about endometrial cancers. It turns out that this woman's father died of colorectal cancer at a relatively early age, and they told her that she should undergo some sort of screening, which she never did. Now she's got 2 bad cancers, and I think 1 more that they haven't resected. So she's in big trouble, this lady. And they're sending her off to the geneticists. So you can't tell what it is, but it's going to be one of those syndromes. At some talk I went to, someone said, oh, well, at what stage do you consider sending people to be tested? And someone said, oh, about 20 adenomas is probably the... I don't think there's any hard and fast rules, but if you have someone with more than 20 adenomas, maybe they should be referred.
Does that change based on age? Or do you...
I don't know, it's just like a rule of thumb. But that's something that I see every day. duodenum. Anyone? Pardon?
I think the villi is attenuated, isn't it?
So that is the follicle.
A lot of lymphoid cells. Looks like follicular.
What's it missing?
Tangible body macrophages.
Yeah, it's missing tangible body macrophages. So it's very blue. Look at the villi next to it. In a normal duodenum, that would be full of plasma cells. Now, I think I can see a couple of plasma cells, but most of them are lymphocytes. That's CD20. So normal CD20, you'd expect the follicle to be positive and maybe a few in between, but definitely not this sheet-like reactivity, and certainly not going all the way up to the tips of the villi. So that's lymphoma, absolutely no doubt. That's CD10. So of course, in a reactive condition, it should be limited to the follicle. This is pretty weak, but there does appear to be some reactivity beyond the follicle. So is this expected? Looks like we've got reactivity along the brush border.
I think it is.
Yeah, it's definitely expected. Because it's used in the pediatric condition microvillus inclusion disease. We get little blebs of the surface in the cytoplasm. So if you do a CD10, you can get these tiny little circles in the cytoplasm with this little pinched off bits of the brush border. Yeah, see, look at all the CD10 reactivity beyond the follicle there. That's definitely abnormal. So BCL2 should be what in the follicle, positive or negative?
Negative.
In
It's not
lymphoma
reactive.
or in
Reactive should be negative.
Yep, so it's supposed to be positive. And BCL6, similar to the CD10, except it's a nuclear marker. So it's getting beyond the follicle. What was nice with this lady is that we had a second biopsy, which I think is benign. So it's nice to compare. Beautiful tangible body macrophages. CD20, so largely limited to the follicles. There's certainly some in between. You notice how we're not getting right up into the tips of the villi. And BCL2, largely negative. Of course, you're always going to find a few positive cells. They're probably the follicular T cells in there, but the majority of them are negative. So this is duodenal type follicular lymphoma. It's got the same translocations as you see in lymph node follicular lymphoma, which is the 1418. Of course, you need to rule out the presence of a systemic follicular lymphoma with adequate staging. But if it's limited to the duodenum or the small bowel, it's got an excellent prognosis. And no one ever dies from it, and they probably don't need any treatment even. One thing I didn't know until I was reading in the WHO book is that, I don't know how reliable this is, but this is the reactive one. This is the CD2135. With your follicular dendritic cell network. So notice the whole follicle seems to be positive. In our duodenal type follicular lymphoma, it's pushed to the edge. You know, as I say, I'm not sure how reliable that is, but the WHO mentions it, and I did it. I went, oh, look at that, nice. is another one. You see them from time to time. You know, the real clue is just that homogeneous follicle. A reactive follicle that big should have lots of gingival body macrophages. So make sure you know your small B-cell lymphoma IHC panel. Know the common fissures that you have to do. See, that's quite significant reactivity up there away from the follicle. And the BCL2 showing really prominent reactivity in the follicle. Okay, this was a tail of the pancreas lesion.
Pancreatitis.
It's not pancreatitis.
Is it a female?
Irrelevant.
We seldom see it.
It's not that. What do you think the majority of the cells are? Epithelial? Yeah, some of them are definitely lymphocytes. So keep thinking. I can promise you if you did a keratin here, everything would be negative.
Ectopic spleen.
Ectopic what?
Spleen.
It is ectopic spleen.
I always
hard.
miss that. I can always miss
The gastroenterologist was onto it. He said this will either be a ectopic spleen or a neuroendocrine tumour. The neuroendocrine markers are negative. It just looks like spleen to me. Probably a few macrophages there and endothelial cells. A lot of blood.
You get them
Can't tell you without the pulse.
And I did a reticulum because they can highlight the sinusoidal pattern spleen. Yes, so that's another heterotropy you can add to your list. So that's highlighting the reticulum that you see in the sinusoids of the spleen.
You say sternunculus, or is that going to be something where you need to know that it's a definite nodule entity?
I don't
Doesn't matter
know.
either way.
Just in the GIT books, if it's in the pancreas, they call it splenic. Ectopic spleen. Again, I know that people at the Royal have seen this one. And over in the liver, there, that's a portal tract. So that's normal. And that's the lesion. So this came in as a lady with bad breast cancer. I said, is this breast cancer? I can tell you it's not. Okay, yeah, I thought it was HCC, and it's a good thought. It's large epithelioid cells, polygonal cells, pink cytoplasm. And I was very sad when the HEPAR one came back as dead negative. So there's the normal liver, there's the tumour.
There's an intranuclear inclusion.
This is the that need to show that the GATA3 was negative, so it's not breast cancer. Go back to the anti-need, eventually the penny dropped.
Yeah, it's adrenocortical.
No, sorry, I think someone mentioned it.
Yeah.
No.
Balloons.
Adrenal.
Sorry?
Roman.
Let's see. That's the Milan A. Yeah, it's a pecoma. Positive for HMD45 and I think the other pecoma markers. And once you think of it, well, it's still a hard diagnosis, there's no doubt about it, but looking through the books, they talk about this perinuclear clearing. See, end of this sort of clearing. There are photos in the books exactly like this for a pecoma. Now, it's very easy if you have the spindly ones and you have the fat. It's harder to think about it when you have, yeah, see that's what you see. It's almost like ballooning degeneration you see in steatocystoma. So put this in to just remind you of thinking about pecoma. These pop up in weird places like the uterus. Sometimes you get them there. Kidney, of course, and tuberous sclerosis. Yeah, I showed it to Ian Brown from Envoy and I said, oh, look, I almost missed this. I thought it was a hepatocellular carcinoma. And he said that when they first came out, there was some USCAP presentation, someone showed it, and there'd been like a US president who'd had something like this. And like every top GI, liver pathologist looked at it and went, yeah, it's hepatocellular carcinoma. But isn't it weird? Like they don't have any risk factors. And then after this talk, he said you could see them all running out to the door, running out to their lab to do the HMB45. And it was a pecoma. So yeah, I guess think about it if you're thinking about an HCC, but it's not right. And it's not right here because it's not cirrhotic. Of course, you can get HCCs in non-cirrhotic livers, but it's just, this is something odd about it. And then, I say, when the HepPAR1 came back as completely negative, I knew I was wrong. And then eventually the P dropped. In fact, there's almost like a vague pigment there. I think some are vaguely pigmented. What else have we got here? I've shown the royal people this one. This is actually it's about 18. Gastritis. Pardon?
Collagenous.
Gastritis, yep. So this is collagenous gastritis. Looks like collagenous colitis, but you're in the stomach. So you got the thick collagen there. I guess I was struck by just how cellular it was. It was so inflamed. Here we go back to IHC, it was negative. Now they had about 5 sets of biopsies from different parts of the stomach because they obviously thought something weird was going on. And some of them didn't look like this, so it was very patchy. Some of them just looked like non-specific. But that's just a really good example of collagenous gastritis. We have a program here. So like you see in the colon, the epithelium can shed off the surface. So they're of unknown cause, it's persistent. They can be associated with collagenous colitis and celiac disease and other things. Oh, and I guess in an adult you need to think about sartans. On the sartan can cause collagenous lesions throughout the gut. I'll just do one last one before we stop. This is a massive lesion in the rectum. They removed endoscopically. So I think they just thought it was going to be an adenoma or possibly a carcinoma or a GIST or something like that. I'm just going to keep you blinded to some of it for the moment. But the mucosa was normal. Got this lesion expanding to submucosa. So, really prominent feature of those foamy cytoplasm. I think that's almost do a count the chromosomes in that. Lots of mitotic figures. So when you look at it, you might go, oh, maybe they're just foamy macrophages, maybe it's some sort of inflammatory lesion, but I think it's malignant. It's too many mitoses, it's atypia as well. Reserve a gong if you can guess what this is, or mitoses. So I guess what would you do? What would you start off with? I mean, I'd probably start off with a broad immunohistochemical panel. Pardon? I didn't do that.
How old was the patient?
Can't remember. Adult, say 40. Pardon?
Is that keratosis style?
Negative. Oh no, there was a bit patchy, but I think it was non-specific.
Melanoma markers?
It's CD45, that was negative. So a good panel to begin with is S100, cytokeratin, and CD45. This is SOX10. This is melanA. What I didn't show you in the original is there are bits that don't have that foamy look. The first thing I thought of when I saw that was melanoma. That's more your conventional look. Melanoma or mitoses. So it's a melanoma with weird foamy cells. Oh, damn it, I'm just having a mental blank. I can't remember what it's called. Balloon cell melanoma. It's balloon cell melanoma. It's unclear at this stage whether this is primary here or whether it's a metastasis. You can certainly get anorectal melanomas. But it was disseminated throughout her anyway, because this was another biopsy from another part of the colorectum. And that was all SOX10 positive. And she's got brain lesions and lung lesions. So she's got metastatic melanoma, but just with this curious balloon cell appearance. So I guess just keep this in the back of your mind when you're looking at skin, and you might have some big nodule that looks like that. Just keep balloon cell melanoma in the back of your mind. I think it's even very rare in the skin.
With the case before, there's something in my mind, the PCOMA, there was some pigmentum or maybe balloon cell melanoma, and you said HMB45 melanate positive, which is PCOMA. Would you consider doing like extra melanoma markers? Like what would be different?
On this one or the other?
On the other one, because it was HMB45 melanate positive anyway, the PCOMA.
Shouldn't it be SMA positive?
Yeah, like smooth muscle
so
markers. Desmond smooth muscle actin. We might call it quits if that's all right.
Yeah.
Thanks very much. Thank you.